The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Welcome to the first episode of the ASCO in Action podcast. This is ASCO's new podcast series that will focus on policy and practice issues impacting oncologists, the entire cancer care delivery team, and the individuals we take care of, people with cancer. My name is Dr. Clifford Hudis, and I'm the CEO of ASCO, and I'm serving as the host of the ASCO in Action podcast series. Each month, I'm going to interview leaders and experts in oncology about policy and practice issues, and I'm going to explore solutions to problems that we're seeing. I hope this podcast will provide a forum for dialogue and for commentary that will allow members and others in our cancer care community to engage with ASCO. For our first guest, I'm delighted to have with me Dr. Karen Winkfield, a radiation oncologist at the Wake Forest Baptist Medical Center in North Carolina and immediate past chair of ASCO's Health Disparities Committee. During her time as chair, Dr. Winkfield played an integral role in developing ASCO's strategic plan for increasing racial and ethnic diversity in the oncology workforce. This was launched in 2017. Dr. Winkfield, thank you for joining me today.
Thank you so much for having me.
I would like to start this discussion with a really basic question, and that is this. What is the current state of racial and ethnic diversity in the oncology workforce? That is, what does our workforce actually look like now?
So while the population of the United States has continued to become increasingly diverse, with some estimates suggesting that by the year 2040, the United States is going to be a majority-minority country, unfortunately, the racial and ethnic diversity of healthcare providers in general has not kept pace. And for example, 13% of the United States population is Black or African American, and 18% identify as Hispanic or Latino. But only 9% of practicing physicians in the United States self-identify as either Black or Hispanic. And this gap is really pronounced in oncology, where only 2% of the physician workforce self-identifies as Black or African American, and 3% as Hispanic or Latino. So we have a little bit of work to do.
And I want to just make sure we're clear about that. You ended by pointing out that this gap was even greater for oncology. So is it clear to us that oncology is lagging the other subspecialties of medicine and some of the other big specialties like surgery or radiology?
Well, as I mentioned, the issue is really pretty global, where the workforce in general, the physician workforce, is not keeping pace with the diversity of the United States. But if we just take, for example, other subspecialties of internal medicine, if we look at the percentage of fellows in internal medicine subspecialties who are either Black or Hispanic, certainly oncology is at the bottom. So when we're looking at cardiology, or we're looking at even rheumatology, infectious disease, there is greater representation, a more diverse physician workforce in those subspecialties. But oncology really probably for about the past 8 years or so has been at the bottom of those internal medicine subspecialties. So we need to look more specifically, are there things and barriers that may be preventing people from looking at oncology as a subspecialty?
Well, that leads us, I think, right into the obvious and most difficult question that I have for you, which is, do we know what those barriers are? Do we know why more people from underrepresented communities don't choose oncology?
It is a very challenging question because it's so multifactorial. As stated earlier, we have a low number of diverse populations when compared to the U.S. population going into medicine in general. And then when we look at oncology in particular, some of this may be related to the fact that the way that the medical schools are set up for looking at specialties, they oftentimes don't get exposures. Medical students may not get exposure to oncology maybe until later on in their course load. Those limited exposures oftentimes are focused on the inpatient setting. So if someone says, well, I really want to be an outpatient clinician, they may be getting a skewed view of what oncology is. In fact, most of what we do is in the outpatient setting. And so if we're only exposing medical students to the inpatient setting, it really is giving them an uneven view of the specialty. The other issue that is really specific to the population of URMs, and that means underrepresented in medicine, those who are coming from the backgrounds that we talked about, African American and Hispanic, that having a lack of minority physician role models is really critical. And so I think that's one of the things that we have to think about as a specialty. Are there things that we can do to bring greater awareness to medical students, but also is there a way to really have a robust way to support the faculty members who are from URM backgrounds so that they can be there to be role models?
Yeah, it's a little bit of a chicken and egg problem, of course, if one focuses on the lack of role models, and it makes sense. How we break into that cycle and make it virtuous, I think, is the question. I do have a related question, and it's been a pet interest of ours for the last few years, and that is, what would you think is the possibility for earlier education intervention, meaning STEM at the grade school, middle school, high school level, to inspire people from these underrepresented communities early so that they, with passion, might select careers in medicine specifically to do oncology?
Yeah, that's actually a really wonderful idea. I think it's a challenge because, I think as ASCO has been so involved in a lot of the issues and related to disparities and diversity related to oncologic workforce, there's also this issue of needing resources to kind of reach back. So certainly, while it would be great to improve the pipeline, we know there are so many challenges in the way that our current educational system in the United States is set up. Much of it is related to wealth and social structure. And, interestingly, I just published a paper with Dr. Vipala from the University of Pennsylvania that was just published in JAMA Oncology about this issue of the financial barriers related to the cost of medical education. And that is something that is really outside of the control of the physician workforce. But certainly if we could go back into some of these earlier folks, and it's not just about high school anymore, we really have to start the STEM education much earlier so that students can be prepared to even think about medicine as a career choice. There are some resources that have to go along with that. And how do we as physicians really utilize our time, whether it be volunteering, et cetera, to set that up? But that's a great thing that we could consider doing. Is there ways that we can tap into pre-existing models and really show that oncology is a great field for other folks to consider?
Well, we think it is, but one of the questions that listeners may have is a somewhat pragmatic one, and I could see some people shrugging their shoulders and saying, okay, I get why this is important on one hand, but can we explain why a lack of diversity has a negative impact on oncology patients? Why do we need to care about this exactly from a purely outcomes point of view?
So there's been lots of data that has been generated over the past few years, past few decades, in fact, that have shown that patients actually do better when they're cared for by providers who look like them or who come from similar backgrounds. And what I mean by do better is not necessarily saying, oh, well, their cancer is going to be cured at a higher rate if they're seen by a physician who comes from that background. It's about how the patients feel, what their quality of life is, and how comfortable they feel in the clinical setting. Comfort levels lead to improved following of recommendations. So there can be patients who get labeled as non-compliant, et cetera, but there may just be a social issue or something that needs to be addressed culturally. And so having a comfort level with your providers, that builds trust. And having that trust between the patient and the care provider is essential. And we all know that oftentimes when we look at our friends and the people that we feel most comfortable with, they're people who come from similar backgrounds, whether it be from a racial, ethnic standpoint or whether it be from cultural, socioeconomic standpoint. And so it's really important to make sure that we understand that this issue of workforce diversity is indeed related to health equity. It's about quality of care, and it really should be a quality metric around how we judge and we look at practices and training programs? And are we doing our best to make sure that we have cultural humility in terms of dealing with the patients that we're caring for?
So are there other impacts that the lack of diversity would have that we need to be aware of, or is that list pretty all-inclusive?
No, one of the things that I think we see in business more so than what we see in medicine is that business has understood for a very long time that diversity breeds innovation. Diversity of thought is important when you want to look at your bottom line, whether it be in terms of revenues, but also in terms of thinking about innovative ways of approaching a problem. So the more diverse the population around the table, the more innovative strategies we can have, the faster we can think about ways to improve cancer care and cancer delivery, the more that we'll be able to have diversity, whether it be from a gender perspective or age perspective, and even race and ethnicity. The more we have diversity of thought around the table, the more we're going to be able to say, hey, this is a problem. Let's look at it from many different angles. And cancer is one of these problems that has so many different angles. It's so many different diseases cancer is. And so why not have diversity of thought so that we can think about this problem in a way that really can move us light years ahead? That's only going to come by having diversity at the table.
Yeah, I mean, it leads to the supposition, although I don't know that it's been studied, that having a diverse employee workforce, and I mean in this case professionals, leaders, and so forth, can improve all of these endpoints that you mentioned, even if your doctor or nurse is not necessarily that precise diversity match. What I mean is a diverse workforce informs the actions of all of the members. Is that something that has been investigated, or is that just something that could be true?
No, you're absolutely right. And in fact, there was a paper that came out in JAMA several years ago. I think Sehal was the first author, where it looked at what happens to the medical students in a system where they do have diverse medical student population. And in fact, not only did the colleagues who were not from a URM or an underrepresented medicine, a background underrepresented medicine, not only did the students benefit, but in fact, faculty benefits. It helps everyone to really look at things from a different way, a different viewpoint. So if we're sitting around and we're colleagues in medical school and we're all going through the same coursework and the same training and we have the same exposures, it does build a bond. Some of my closest friends are the people I went to medical school with. And so it enables them to have questions and to ask those questions that they might not otherwise have asked. So if I have a white colleague or a colleague who may be from Southeast Asia who wants to ask a question about a patient who may be African American because I'm an African American, and they can ask that question without there being judgment. But it also allows for people to realize that they have their own biases, right? So if you have a diverse population in a course or in a training program, you really have to deal with some of your own biases. And it does allow you then to be a little bit more respectful when you're dealing with patients.
That's really good, I think, and that's just another reason for us to start to focus on solutions. So given that, I would like to switch gears, and let's talk for a few moments about something that I know has been a passionate effort of yours, and that is what ASCO is actually going to do to increase diversity and cultural competency across the oncology workforce. Again, I pointed this out before, but you were instrumental in the development of our strategic plan to increase the racial and ethnic diversity in the oncology workforce. I have to point out that long phrasing is the actual title of the document. It is a mouthful, but how was this plan created? Tell us about that.
Well, as you know, ASCO has really engaged in many efforts designed to support and promote diversity in the oncology workforce for years, and that had been primarily through its Diversity in Oncology initiative. But one of the things that we were tasked with is looking at, are there things that we need to do that are more specific that may actually help drive this issue in terms of pipeline, if you will? How do we then reach back and make sure that we're opening up doors and reducing some of those barriers? So really, to think about this, we decided to have a strategic plan. We went to the board and said, is this something we could do? And ASCO completely jumped on this and said, this is something we need to do. So what we did was we convened a working group. It was composed of members from the ASCO's Health Disparities Committee. You mentioned that I was the previous chair of that. We also included members of the Professional Development Committee of ASCO and ASCO's Workforce Advisory Group. So all of those individuals, so the Health Disparities Committee obviously having a focus on populations and physicians, making sure that we're caring for diverse populations, but obviously Professional Development and Workforce Advisory Group really understanding the lay of the land, if you will, the landscape, making sure that we brought all of those members together in addition to other stakeholders. So we also included in this group trainees who are from backgrounds who are underrepresented in medicine, and also other thought leaders. We put everyone in a room and we actually sat down and we said, what are some of the things that we needed to do? Out of that round table came the bones of the strategic plan, and really many of the steps that are outlined in this in the diversity statement, the strategic plan, really came out of that meeting.
So that's great. Can you share with us at a high level what the goals of the plan actually are? What are the deliverables?
So there are a few deliverables. I think it's really important to remember that ASCO as an organization can impact some things and there are some things it can't. So that was the other thing we needed to make sure that the things that were put in the strategic plan were items that we may be able to actually impact. And so a couple of things that we wanted to do with this is, number one, to establish a pathway to increase workforce diversity. There are three primary goals. One is establishing a pathway to increase workforce diversity. The next is enhancing diversity within ASCO leadership. It's important to set the example. And the third is integrating a focus on diversity across ASCO programs and policies, including the annual meeting, and making sure that our colleagues who may not have exposures to diverse populations can understand some of the challenges in that population, but also bring forth some of the amazing work that's being done on the ground to try to not only improve workforce diversity, but also to improve health equity, cancer health equity.
So that's great. Are there a few tactics, what we would call steps, that you could highlight that would clearly show us that we can begin to make some progress towards these goals?
Yeah, so let's take, for instance, the first goal that I mentioned in terms of establishing a pathway to increase workforce diversity. ASCO understands the need to provide opportunities for minorities to have mentoring, but also clinical exposures early in the course of medicine. And so not only do we have medical student rotation, that's been an initiative that ASCO's had for many, many years that provides a clinical research oncology rotations and mentoring opportunities. But there's also more thought being given into a formalized mentoring program that really can reach out to students that are from backgrounds that are underrepresented in medicine, so that ASCO can take the lead in terms of exposing students along the continuum, including fellows, to careers in oncology. Another, for example, is really thinking about ways for just integrating the focus of diversity and disparity throughout the programs, as I mentioned. And so there is a huge initiative at the Health Disparities Committee to really be a part of the educational committee and really thinking about each of the program tracks, and are there ways that we can think about health equity to know that, again, that members who may not have exposures will understand that some of the barriers to healthcare may indeed be ameliorated or at least lessened by having a diverse workforce.
So going from the high level, what can ASCO do? What does this plan call out to the more front line? If I'm an individual ASCO member, what can I do personally to support the goals of this strategic plan?
So hopefully the ASCO members will really join in this effort, whether it be volunteering to mentor. There's a new wonderful volunteer corps, which is a great opportunity for individuals who may not have had exposure to committee work in the past to really volunteer. But the biggest thing is being available. Asking ASCO members and non-members even to think about becoming a mentor. You can mentor whether you're in the academic setting or if you're in a community setting. Everyone needs a mentor. And it could just be that exposure, having a student shadow you, which really can make the difference. I met 2 students today who are applying in radiation oncology who said they don't have radiation oncology at their institution, but it was the kindness of a mentor, someone in the community nearby who allowed them to shadow that really made the difference for them. And those simple things, particularly early in a medical student's career, can really make the difference. So hopefully people will consider the mentoring aspects, encouraging people to look at oncology in a different way. For those who may be seeing and meeting students in the inpatient setting, inviting them to see what's happening in the outpatient setting. And then we have got to be out in our communities talking about the work we do, especially going back to your question about, is there something we can do to improve the pipeline? Making sure that we're out in the community, even talking to folks at colleges and universities or even at schools, so that we can encourage individuals to consider a career in oncology.
Well, I can't think of a better way to sum up the passion, altruism, drive that all of us I know bring to the field. And I want to thank you once again for joining us today for this inaugural ASCO in Action podcast, and for what I found to be a great discussion on a really important issue.
Thank you so much, Dr.
If listeners would like to learn more about ASCO's diversity initiatives or want to get involved in some of the ways that Dr. Winkfield outlined in supporting the implementation of this strategic plan, please visit us on the World Wide Web at asco.org/diversity, and stay connected to cancer-related policy and practice news through our ASCO in Action newswire service. That's available at, and this is one word, ascoaction.asco.org. Until next time, I want to thank Dr. Winkfield for participating, and I want to thank all of you for listening to this ASCO in Action podcast.